Welcome to this podcast episode of our Fragility Fracture in Focus, aimed at all doctors involved in the care of patients suffering from osteoporosis. In this podcast, we will explore and discuss the hottest topics, scientific advances, vision, and innovation in the bone field. The aim is ambitious, yet simple: to elevate the importance of secondary fracture prevention together so we can work towards a world free from fragility fractures. I am your host, Cesar Libanati, Head of Medical Affairs and Medical Strategy at UCB, and in each episode, I will be asking leading experts and sometimes patients from their unique insights, experiences, and practical tips in osteoporosis management. Across the 4 episodes planned for this year, we will focus on the 4 pillars of the P4 model, a framework increasingly recognized as a cornerstone of proactive modern medicine. The 4 Ps stand for prevention, personalization, participation, and predictiveness, which brings us to the title of today's podcast: Breaking the Fracture Cycle. We will discuss improving the prevention of subsequent fractures and the progression of osteoporosis. For that, fracture liaison services, commonly referred to as FLSs, play an important role. The implementation of FLS is perhaps the single most important action that can be done to directly improve patient care and stop the spiraling fracture-related healthcare costs worldwide. A recently published study, authored by Professor Qasim Javed, attested that FLS's effectiveness can be very high and highlighted its importance in this space. To tell us more about FLSs and to discuss the relevance of prevention of subsequent fractures, we have the pleasure today to have Dr. Maria Talla in our podcast. Dr. Maria Talla is leading the FLS at the University of Glasgow in the UK. Welcome, Maria. May I ask you to briefly introduce yourself and perhaps tell us what made you interested in the field of osteoporosis and fractures?
Thank you very much, Cesar. I'm a consultant endocrinologist and I'm based at the Queen Elizabeth University Hospital in Glasgow. I have been running the fracture liaison service there since 2020, and my primary interest in fracture liaison came about during my endocrinology training, where I worked alongside 2 consultants, Stephen Gallagher and Andrew Gallagher, both of whom influenced me to develop an interest in this field. And I realized that I had a personal interest in osteoporosis on the back of some family history. Both my grandmothers had fragility fractures in later life. On my maternal side, my grandmother had a hip fracture, and on my paternal side, my grandmother had multiple vertebral fractures. And I saw how both of those events really drastically changed their quality of life. And it influenced me at an early stage of my career to think about what I could do as a clinician to improve the pathways for post-fracture care that patients receive in order to make a difference and reduce their risk of having fragility fractures in the future.
Thank you, Maria. Thank you for sharing also your personal experience, and you're absolutely right. The impact, particularly in a family member, a close family member like your grandparents, can have from a fracture, particularly a hip fracture, can be really life-changing, and certainly it looks like it has for you. So on that, let's jump into the meat of the subject. Why are subsequent fractures such a big part of the conversation today about osteoporosis management?
I think we all know and recognize that fragility fractures are very common. We know that it affects around 1 in 2 women, 1 in 5 men over the age of 50. And in the UK, we see around 500,000 fragility fractures annually. And these fractures are really costly. We know that hip fractures alone account for a very large proportion of cost to healthcare, equating in the UK to around £1.1 billion. And on top of that, there's the additional cost of social care following a hip fracture. And it's a missed opportunity for prevention, because we know that around half of women who have a hip fracture have had a previous fragility fracture in the past. And that really is, to me, a striking figure. And fracture liaison services really present an ideal opportunity for us to intervene in order to try and prevent these hip fractures from occurring, allowing us to introduce effective treatments and therefore reducing the burden of fractures and improving the outcome for the individual patient.
Yes, I thank you for that. I wholeheartedly agree. You cite that almost half of the patients who present with a hip fracture have already had at least one previous fracture. And I suspect many of them are not on any form of treatment or any form of management of their osteoporosis. So that represents a tremendously missed opportunity. Wouldn't you say so? And if so, I thank you for the work you're doing, but why is it important, and who should get involved indeed in recognizing that so that we can further prevent subsequent fractures?
I think that you're absolutely right in what you say, Cesar. We know that once you've had one fracture, you're at 2 to 3-fold higher risk of having a secondary fracture, and around a quarter of secondary fractures in women who are over 50 occur within the year, the first year of that index fracture. And I think, to me, that's a very important concept when talking about fracture liaison, this concept of imminent risk, whereby the risk of the second fracture is very much highest from the first 12 to 24 months after their index fracture. And that's really where I think that intervention should be targeted. And we should all be thinking about, within our local services, how we can create methods of identifying these patients systematically and offering them an assessment through a fracture liaison service, getting them started on treatment to reduce their risk of having a future fracture, and all of that being done in a timely fashion.
Thank you, Maria. So if I understand you correctly, the risk of having another fracture is highest in the 1 or 2 years after the fracture occurred. Yet, as we know, most patients go unassessed and untreated. I think statistics talk about 80% or more in most countries. Now, the risk, or actually the incidence of another fracture is what in the next 2 years? 15%, 20%? Does depend on the fracture, on the side of the fracture?
Yes, and I think that when you're talking about the opportunity for intervention, to me, one of the main opportunities here, or missed opportunities, is around vertebral fracture identification. And I think the number there is around 55% of these people who've had a major fracture like a hip fracture will have had a prior vertebral fracture that is unidentified. And we know that these fractures are very difficult to pick up. There are types of fractures that are easy to pick up, fractures that present to hospital that require inpatient admission. It's much, much harder to pick up a fracture where a patient may not present with symptoms, and that's the kind of umbrella in which vertebral fractures sit. So I think that if we can get in there and identify these patients, that's certainly a great opportunity to improve care.
So it's interesting because the topic of vertebral fractures, as you very well say, commonly totally missed or not identified, keeps coming up. In the previous podcast with Professors Eastel and Professor Langdell, the importance of vertebral fracture was also highlighted. Now you have introduced, and we'll talk more about that in a minute, a number of improvements to create efficiencies towards the recognition and identification of fractures. Do you think There's lots of work to be done there. And is this something that you're already centering in, identifying those quote unquote silent vertebral fractures?
Yes, I think we're making a lot of good advances on that front. So we might be talking about that later, but in terms of where we are just now with the changes that we've made with our systems in Glasgow, we have significantly improved our ability to identify these silent vertebral fractures and getting these patients prioritised for assessment through our fracture liaison service and allowing them access to DEXA in that context.
Wonderful. Now, you mentioned Glasgow, and I cannot but say that Glasgow is a very important place in the history and the setting of FLSs. For those that do not know it, Glasgow is where FLS was born. The first FLS was indeed in Glasgow, and you alluded to that, the Gallaghers that had a very significant impact. Yet, that was 20 years ago, correct? And it took, maybe 10, maybe 15 years for FLS to come back into the arena and starting to progress and starting to disseminate across the world because their impact is obvious. Now, tell us a little bit about the original FLS, perhaps briefly, and also about some of the improvements that you have made to that first type of FLS. What do they mean? What has been the impact so far? And then we'll talk about what is your vision for the future, what else, what ambitions you have, what do you need for those to be realized. So let's first talk about, again, a little bit of the basic FLS, what an FLS is, and then how you progress it to the next level of performance.
So our FLS here in Glasgow, set up in 1999 by Stephen Gallagher and Alistair McClelland, and they recognised that if we were able to identify patients who were over the age of 50, who had sustained a fragility fracture, and offer these patients investigation, information, treatment, and referral to onward services, we would be able to reduce that individual's risk of having a further fragility fracture. And I think that methodology is the underpins fracture liaison services. When we first set up fracture liaison service in Glasgow, it was very much centred around our team of osteoporosis nurse specialists, and they work incredibly hard to case find and assess these patients who've had a fracture. The FLS model that we have in Glasgow is based in hospital, but there are certainly also FLS models that are based out of hospital. And these models require support not just from the osteoporosis nurse specialist, but also from a clinician. And this is usually a consultant or a primary care physician with an expertise in osteoporosis and fragility fracture prevention. And the foundation of any FLS model is that when you're looking to identify patients, the approach that you take really must be systematic. And I think of this as sitting under three distinct categories. I touched before on the first category of inpatient fractures. The second group to me are the outpatient fractures. And the third group, which is the problematic group to pick up here, are the vertebral fractures. And the inpatient fractures really are the low-hanging fruit. You know, these patients are fairly easy to identify because they've required hospital care for their fracture. And they're usually among the highest risk of having another fracture in the future. And the way we pick this up in Glasgow is by liaising with our orthogeriatricians. We look at hospital IT systems to identify patients who are admitted to orthopaedic wards. And we also look at trauma list again, patients who are having operations because of a fracture. And those are, as I say, very, very straightforward to identify. Outpatient fractures, again, along the same lines, relatively easy to identify these patients. We use hospital IT systems again. We can look at fracture clinic lists, whether those are patients who present face-to-face or who are reviewed virtually, and also looking at attendances at the emergency department. So to me, that really the group of patients who present with vertebral fractures are the most challenging. These patients are often not admitted to hospital. They may be asymptomatic. They're not seen at the virtual fracture clinic. And they often have fractures that are picked up incidentally on imaging for other reasons. And our original FLS model in Glasgow, when it was set up in 1999, it sought to identify these patients by way of liaising with our radiology colleagues, and they provided us with a list of scans involving the spine where the word fracture was reported. And at the moment, we no longer use this model. We changed over to our new model in November of 2022, and that's really advanced the care that we deliver, and it's significantly reduced the amount of time to vertebral fracture identification.
No, that's wonderful, and I'm familiar. Actually, the world is noticing the improvements in terms of efficiencies in order to use technologies, as you just mentioned, to have better identification and a better outcome of patients. So, would you like mentioning a few other ideas and specifics that you put in action in your FLS?
Absolutely. And I think the background of all of this, the driving force behind change for me was that I had very limited exposure to the inner workings of FLS as an endocrinology trainee. And when I was first appointed as a consultant, I made it my mission to understand FLS. And I spent quite a lot of time with our osteoporosis nurse specialists, just having conversations, understanding how they work and what they did every day. And I remember the very first time I was told how they identified vertebral fractures, I was really shocked to see that they were given a spreadsheet, printed out sheets with hundreds of patient identifying numbers on it. They then had to enter this identifying number manually using multiple hospital IT systems, reviewing the radiology report, assessing laboratory data, looking for previous prescribing information and DEXA data. And they often, because of the time constraint, they often were not able to assess all the patients on their list at any given point. And that meant that the list built up over time. And at the time that I joined the service here in Glasgow, we were performing very well at identifying the inpatient and outpatient fractures. But in terms of identifying the subgroup of vertebral fractures, it was taking us up to 18 months to pick up these patients. And what we did with the support of a grant from Innovate UK, we worked to develop from the ground up an FLS system that would automate a lot of our existing manual processes. And the result of that the result of that work is we now have a single screen clinician dashboard which contains information that allows our nurses to easily triage patients. That has cut down significantly the time to vertebral fracture identification. I mentioned previously it was 18 months. It's currently sitting at a matter of days. The way we've done that is by building data integrations across a variety of NHS IT systems. Every morning, it presents our nurses with a list of patients on a screen who have met the criteria for FLS. And it also displays previously coded fractures. We've identified specific laboratory data relevant to bone health. We're able to also present any previous osteoporosis therapies and medications relevant to bone health and any prior bone densitometry data. And all of that information is present on a single screen. We've gone a little bit further over the last couple of weeks in terms of doing more to automate that process. We've introduced a real-time audit tool, and that audit tool now shows that we're identifying a lot more fragility fractures and vertebral fractures than what the projected number based on the NHS England model set out in FLSDB. And all of those efficiencies add to freeing up nurse specialist time to speak to patients and to allow us more clinical time to advance fracture care.
Maria, I have been in the field for over 40 years. It's been a privilege, but I have to tell you one thing. You are a breath of fresh air. So it's wonderful and listening to you and noticing your expertise and indeed your passion for this very important. Now, you must be proud, but what are you most proud of?
I think that's quite a difficult question.
Sorry
I
to
think
put you on the spot.
not at all, not at all. So I think this has probably been my proudest innovation in terms of fracture liaison. It's made such a huge difference both to our nurses and our patients. And I often, I often have conversations with other FLSs who and we all struggle with the same problems. It's really a daunting task to be faced with, trying to pick up all these patients and deal with them and manage them through an FLS in an appropriate time frame. And I think the introduction of this has really, really changed things for us, not just from a kind of clinical point of view, but the new system that we've introduced has also got other efficiencies. It's automated the movement of letters from our FLS to the patient's primary care physician. We're now building on automating aspects of the medication review process. So we know that the compliance perhaps to osteoporosis therapies can wane over time. And we offer patients an assessment at 4 months and 12 months following the introduction of osteoporosis therapy to ensure that there are no issues with that. And that's also now being built onto our new system. So I really am very, very proud of all the work we've done as part of this project.
Yes, and it is a team effort, of course, but a team always needs to have a leader. And I get the feeling that you're being recognized as a leader, and your team members are thankful for that, and your patients, I'm sure, are thankful for that. Do you have any specific feedback or words that you recall team members telling you or patients?
Yes. So I recently had a patient in my clinic, and she was really relieved to know that the back pain that she'd been told was just old age was in fact due to vertebral fractures related to osteoporosis. And she was one of the patients that we picked up using our new system. She was absolutely delighted that she was able to get a diagnosis, get started on treatment to reduce her risk of a future fracture. And our patients really value the FLS model that we have, which is a one-stop clinic. We're able to offer patients a DEXA scan, offer them a clinical assessment, and get them started on treatments where appropriate on the same visit. And I think that's all been very positive.
That's wonderful, and it's so nice to have all this positive reinforcement and feedback. Now, I'm sure there's also been challenges, and there's been times that you had to deal with issues that made you perhaps question what you were doing. Would you mind commenting about those, and what were your key learnings from those, and any advice you may have for those that are starting FLSs?
So I would say that one of the challenges that we have now is that we are so much better at picking up fragility fractures that we now have many more patients being assessed through our FLS. And on the whole, I would say that there's definitely a lack of prioritization of policies on a higher level to support FLS. And that includes support for funding clinician time, funding nurse specialist time, and also funding the provision for DEXA. And as a service, we're always looking for ways to improve our access to these resources. And I think a lot of that is around raising awareness, putting osteoporosis out there, and raising awareness of the disease and the support for that. And my key learning point from all of this is really that technology is here to help us deliver better care to our patients, and we shouldn't be afraid to use it. And it's about learning what are the current inefficiencies in your FLS system, and how can you make those inefficiencies better? Even if it's a small change, it can make a huge difference to the overall service.
And I'm sure, as your name is already very well recognized, you have the possibility of talking to people who may be interested in or have some questions and challenges, and you'll gladly provide your experience and feedback. Is that a fair statement?
Absolutely. I've spoken to many FLSs around the country, and we certainly are very willing to share our experience and help build better FLSs elsewhere.
Thank you for that. Perhaps one last question. Many FLSs, even today, are only operating on the low-hanging fruit, as you said, correct? The patient who had a hip fracture, who's sitting or laying in a hospital bed. And in the original FLS in Glasgow, they went after all fragility fractures from the go, which I think was a very important aspect of the work. How important do you think it is to indeed have the ambition early on in the FLSs, or for those FLSs that are already working, to increase their reach to capture all the fractures ideally, or at least what we consider the major osteoporotic fractures? Is that something that you advise very strongly, or would you say, well, do as you can?
I think it's very difficult if you don't already work in an area with an established FLS, and I suspect it seems like a very daunting task to take on the Glasgow model of picking up all fractures, not just the inpatient or admitted fractures. I think that many places will opt to start small, as you say, for offering assessment for a specific type of fracture cohort. And I think certainly having that type of FLS is better than having no FLS. But, this is all about secondary prevention and that missed opportunity. In my view, once you've had a hip fracture, there's so much comorbidity and mortality as a result of that event. And what you want as an effective FLS is to be able to prevent that hip fracture from happening. And really the way to do that is by making sure that you're making steps to identify these other non-admitted outpatient or vertebral fractures.
Thank you, Maria. So that brings us to the topic of indeed then intervening in these patients that are identified, and the treatment rates and the treatment persistence remains in our field a big issue with, again, numbers that I don't even want to mention them because we're ashamed of them. Now, if I make a comparison, from you're saying the refracture rates in the next 1 or 2 years could be as high as 15, 20, maybe even higher for patients who have vertebral fractures. And that is actually higher than the incidence of a new MI or somebody who just had a myocardial infarction. And yet, it would be unthinkable for a patient to go through the medical system today with a myocardial infarction and not leave the hospital with a plan where they will already be started on a statin, a beta blocker, and an aspirin, correct? No questions asked. And yet, the mentality is not yet there for osteoporosis. Why do you think that is? And what can be done perhaps to try to go to the model of the cardiologist?
I think there's very much the perception out there on, when you speak to patients, they just think it's a broken bone. Many of them think that it's just a broken bone. But there's perhaps a lack of understanding of the wider implications of what fractures can cause in terms of causing significant things like patient disability or pain, losing the ability to lose their independence and their social mobility. And I think all of those things are important, and it shouldn't be perceived simply as just being a broken bone. And I don't think that fault is on the patient side is very much the viewpoint of some clinicians as well. And I think it's about getting that message out there that about secondary fractures, about the fact that this is a very treatable condition with the introduction of appropriate preventative medicine.
Maria, I'm wondering if you have an opinion on the potential impact of having an FLS being actually reimbursed through the healthcare system. And the reason I'm asking is that in some areas of the world, Japan being one that comes to mind, now FLSs are being reimbursed. Do you see that as potentially having a positive impact? Is something that will be very welcome, needed? What are your thoughts?
I think certainly in healthcare systems where it's based on reimbursement, that model, I'm sure, is very effective. As you know, without reimbursement in these types of healthcare models, there's very little incentive for the healthcare setting itself to advance fracture care. And I think if that's the model that works for the site, such as Japan, as you say, then that is a very good model to implement. I guess the question is around what fractures are you implementing that model for at the moment for hip fractures? But again, we should be driving for more change and looking to broaden that to offer reimbursement to other types of fractures as well, not just hip fractures, but vertebral fractures, I think should be the next step.
But in Scotland, I understand that the FLSs are not necessarily reimbursed. The work is being done because, hey, let's call it what it is. It's the right thing to do, isn't it?
Absolutely. And we operate an FLS model on the basis of the fact that we know that FLSs are cost effective. It's the health economic benefits of FLS have been demonstrated, and as a result, the patients receive the care that they deserve because it's the right thing to do.
So, Maria, a big thank you. It's been lovely to listen and learn from you, not only from your expertise, but about your passion and enthusiasm and your experience about running an FLSs. I think our patients, the listeners to the podcast, and UCB is extremely thankful for all you're doing and for your candid sharing of all you've done in order to improve in the field. I thank you again for that. For those who may have missed it, our first podcast entitled Predicting the Future of Osteoporosis, released during ECTS, is now available. So on that, Maria, again, a big thank you. And now you all go and have a wonderful day.
Thank you very much, Cesar.